Good morning, everyone. My name is Deborah Rathjen, and it's my privilege to welcome you to this 5th annual Bionomics MSD Frontiers in Neuroscience Symposium. Today we're going to learn about feeling and forgetting, with many exciting topics that will cover post-traumatic stress disorder, pain, sleep, and Alzheimer's disease. So in this subject selection, we've got a lot to interest all of you. As I said, this is the 5th year of the symposium, and it's now become a regular on the neuroscience agenda in Australia. It's a very exciting program, and it's one that I think everyone will enjoy. First up, I'd like to thank the Bionomics team, including Dr. Sue O'Connor, our VP of Neuroscience Research, Carolyn Coles and Dr. Lauren Nicotra, but I think also the entire neuroscience team should be very proud of their efforts in putting together this symposium with the very great support of our MSD colleagues. So thank you, Team Bionomics and Team MSD. This year we have 230 registrants, and it's actually our biggest year yet. We're hoping this symposium will grow, continue to grow, as there are many exciting topics to canvass in this area of biology, drug discovery and drug development. This year we have the support of AusBiotech, and it's wonderful to have them on board. This year's event is a satellite symposium of the AusBiotech National Conference. So thank you, AusBiotech. Bionomics and MSD have been in a strategic relationship for a number of years, and this symposium was proposed by MSD. In fact, it was proposed by Richard Hargraves as a way to celebrate our shared endeavours. Our relationship with MSD has been built on a foundation of strong science, a genuine desire to make a positive difference to patients' lives, and a mutual respect and commitment to continue to build on the collaboration. Further evidence of that came through an exciting development earlier this year with the commencement of a phase 1 clinical trial of a therapeutic candidate for the treatment of Alzheimer's disease. As a result of achievement of that milestone, Bionomics received a US $10 million cheque and a bottle of 2006 Dom Perignon from our MSD colleagues. Thank you, MSD. We're really delighted to reach such a significant milestone and looking forward to continued success in that development program. Let's get the proceedings underway now. And I'd like to introduce you to the wonderful Dr. Ian Bell from MSD. It's been an absolute privilege to work with Ian over the last few years to get this therapeutic candidate into the clinic. Not only is Ian an all-round nice guy, he's a superb medicinal chemist with an impressive CV. Educated at Cambridge, postdoced under a NATO fellowship at the Scripps Research Institute in San Diego. He's been with MSD since 1999. Come up, Ian, and introduce our first speakers. Thank you.
Thank you, Deborah, for the kind introduction. And I don't want to take too much of your time. I want to get right to the scientific talks, and it's my privilege to introduce our first speaker, Professor Steve Williams, who's the founder and head of the Department of Neuroimaging at the Centre for Neuroimaging Sciences at King's College London. Steve has co-authored over 700 papers, and among his many distinctions, he has been elected a Fellow to the Academy of Medical Sciences. He's also recently made it onto Google's top 500 most highly cited researchers of all time. And we just worked out that he supervised me as an undergraduate when I was studying physical organic chemistry at Cambridge. For the past decade, Steve has really been focused on making brain imaging an essential clinical tool in neuropsychiatry, and he continues to develop innovative imaging methods to measure structure, function, physiology and metabolism. And he's going to be talking about a lot of that work today. And the title of his talk is Magnetic Resonance Neuroimaging to Facilitate the Drug R&D Process from Mouse to Man. Please welcome Steve.
Thank you, Ian. I'd like to have 10% of all royalties from all of Ian's fantastic organic chemistry over the last 30 years, and I would be a wealthy man. Yeah, thank you for the invitation to be here today, and it's pub time in the UK as I speak, so I'm probably on my best form for the next half an hour, but after that I might just slip away. So yeah, I've worked with Bionomics over the last couple of years with Professor Alan Young, who's in the front row, on BNC 210 for GAD, and you'll hear a lot more from Sue O'Connor about that this afternoon, and that study went swimmingly. But what I'm here to talk about for the next 30 minutes is MRI in particular, magnetic resonance imaging. It's a methodology that has had more makeovers than Madonna. Every couple of years, a new technology comes along, whether it's to look at the chemistry of the brain, or the physiology, or the function or metabolism, or the interaction thereof. And so their challenge, having come up with all these lovely scanning techniques, is to make them clinically useful and then impact on the drug R&D process. And I'm hoping over the next few minutes to give you an idea where the engineers and the physicists are trying to help on that. So how are we going to make this sort of technology useful for the clinic in psychiatry? Well, the first thing to do is take a leaf out of the book of Steve Jobs. We said there's no rocket science to making the best scanners for what we need to do. Just work back from what the patient needs. And in my case, I had a mother who was in her 70s who needed a scan. I had a son who was a control subject for an autism trial, and I had a daughter who was involved in an ADHD study. So they all gave me feedback on exactly what's needed, and I'll talk you through what we had to do. The first thing my son said when he got in the scanner, "I can't lie still, Daddy. When you tell me to lie still for these scans, I just move around. Just like if you were taking a selfie on your phone, if you're moving, it's blurred." So Jim Pipe and others in the US came up with this brilliant idea. Instead of building up the scan line by line as a raster on the left, he said, let's make it into a propeller. Let's have blades of the propeller, and at the center of the blade of the propeller is a common reference point. So if you do move, as he did in the left scan and in the right scan, you can always register it afterwards. And you end up with an image that's pristine, that's diagnostically useful, even if you are struggling to lie still. So that means if you're doing a dementia trial and you're in the late stage of dementia and you're struggling to lie still, you can still get something useful. So when you're looking over those 2 years of decline, you can actually resolve exactly where the changes are in the brain, having been able to get a beautiful image at each visit, as long as they stay inside the machine. When my mum had to have a scan, she had a transient ischemic attack. It's like a minor mini stroke, and she was quite sort of proud about going in one of these scanners that her baby boy had helped develop. And as she was going further and further inside the machine, she went, whoa, 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 why am I going inside this machine all the way as far as my ankles? You only need to look at my head. So with that in mind, we're now starting to develop scanners that are just for the head. Over 40% of all MRIs are for the head. At the higher field strength scanners, it's more like 70 to 80%. So why are we making these massive, expensive machines where you just need to look inside the brain? And she said even more, well, I've got a bad back and you're making me lie down inside this machine with my bad back. Why can't I have a machine just like one of those hair salons when I was a child? So we're not there yet, but if Ian remembers his undergrad days of chemistry at Lensfield Road in Cambridge, we were putting samples into NMR magnets, which are vertical. And so we just have to expand that technology and be able to start doing those studies when people are sitting down instead of lying down. So if you're doing a phase 1, early phase 2 study with drug R&D and you're worried about nausea, you want to be sitting up, not lying down when they're testing that new drug. If you want to look at eating, coughing, sniffing, olfaction, typing, writing, gaming, you name it, you want to be sitting down instead of lying down. So that's where we'll go in the future. But let's make baby steps. So we've worked with GE on a head-only 3T horizontal MRI. The first prototype's in Mayo, and we're going to hopefully have our first in the UK in our clinical research facility next year. So we can start doing studies with people where they're just in as far as their shoulders. The chief exec of GE said to me, I can see all the scientific reasons, but give me an emotive reason I can help sell this and market this. And I said, well, I want to be able to hold my son's hand when he's having a scan. And they said, sold, that's it. With these types of scanners, you literally are going in as far as your shoulders. So that's where we're going with this technology. So my daughter had a scan, and it was part of a study in autism, again, and the big issue, of course, with these scanners, I don't know if you've ever heard them, but they're bloody loud. So if we can make it less claustrophobic, and if we can make the scans quicker, and if we can make them motion insensitive, can we also make them silent? So if I can get Reese to play that sound file. Please, Reese, I hope. Thank you. So that's a modern functional MRI. We've turned the volume right up, so all you're hearing is the background noise of the pumps and the noise coming across the microphone. So by the end of the decade, if we're still doing noisy MRIs, there's something wrong with us. We've now got the physics right, and that's 2 members of my team have been doing that over the last few years. So we've got studies later on today about insomnia and sleep disorders. Think about the studies you could do now during sleep. Think about the studies of auditory hallucinations. Think about the studies in autistic kids, of which about 15% can't tolerate loud noise and bright light. We'll be able to do all those studies in the more extreme conditions. And of course, our anxious patients, which is something we're doing a lot of work on, will tolerate this much better, I hope. So watch this space. But back to the day job. So what I've been trying to do for the last 20 years is try and show there's a biological underpinning to all of these psychiatric disorders. There really is a difference in the brains that we can pick up, and it's not just all in the mind. So if you look at the meta-analyses, the literature, if you look out there, you'll find that you can pool this data and you can start asking really simple questions like, a bit of the brain called the hippocampus, that little bit that's delineated in red, is it different in the psychiatric disorders? And of course, the obvious one to look at the bottom is dementia. That 0 line is normal. But if you look at the left and right, there's a dramatically smaller hippocampal volume for Alzheimer's disease. And so we know that's a typical classic biomarker that's now used to sort of flag someone that might be suffering from dementia. But can the same technology be used to look at other disorders? PTSD, right at the top, same types of scans, same type of analysis, yet their hippocampi are smaller. Now, is it a consequence of the trauma, or is it they have a smaller hippocampus to start with? We just don't know. So that's something that needs much more research, but there's a biological underpinning to that. Things like major depression, it's smaller, at least when they're not medicated and when they're suffering from the condition. Whereas bipolar, it's not smaller. So now we start thinking, oh, perhaps if someone presents for the first time with a mood disorder, armed with a quick scan like this, we might be able to get to the point where you can discriminate between major depression and bipolar before you give them the wrong treatment and exacerbate a manic attack. So that's where we're going. Schizophrenia, obviously there are changes there, but we're not just limited to looking at changes in the hippocampus. The ventricles might be bigger, the hippocampus and the amygdala might be smaller, some of the bits of the deep grey matter, which is shown in blue there, might be medication effects, but the bottom line is it's not just one little bit of the brain that's changing in the condition, it could be across the whole brain. So how are we going to look at that? How we might be able to look at each little bit of the brain to see what condition they have? Well, your eye does this all the time. If you look at those two pictures, if you look at just one feature of those pictures, so whether it's the necklace or the pearl earrings or the hair, you might not be able to discriminate between an actress and another actress. But if you look at the whole picture, your eye can tell those apart. So now we're starting to use machine learning approaches to actually discriminate between patients and controls, responders and non-responders, people that are going to decline into disease. So very simply, you take a bunch of scans, expertly labeled by our clinical colleagues, versus matched controls, run the algorithm, and you can produce a discrimination map so that when a new subject comes along, you can benchmark against that database and say, what's the probability of them having the condition or not? So these machine learning type approaches are now really taking off in the field, and we're doing that more and more, which will make the scans hopefully cheaper and simpler, because if you make a cheaper scanner and you can automate the way of classification and diagnosis, then we can get to that $100 assay that will impact on the whole drug development process. Our aspiration is to do the same for psychiatry that the cholesterol test did for statin development for the likes of Pfizer. So here we have an example where we have a whole plethora of dementia patients versus controls. They've had a quick structural scan, and just from the structural scan itself, you could tell with 75% accuracy they've got dementia, and where in the brain was driving that distinction between the two groups. So that's exciting. It's not brilliant. You talk to the marketing departments or the diagnostics, they say you've got to improve on that. So you build in other information. There may be a second type of scan, and there might be some other blood-based measure as well. And that combination of those measures come together, and you could predict 2 years before you have dementia who's going to get it with over 90% accuracy. So this could really inform future stratification and enrichment of populations for drug studies. Instead of having to take the heterogeneous samples that you have, hone in much tighter sample, those people that are likely to develop dementia, and then target those for your more aggressive interventions. The same principle applies to conditions like psychosis, and much of that pioneering work was done here in Australia. And the idea being is, can we perhaps look at those people at risk of developing psychosis? They've got a first-degree relative of the condition. They are presenting with these soft signs. And within 2 years, about 15% of those will go on to develop and have their first psychotic event. Just like with epilepsy, the more events you have, the more kindling effect and the more damage that it causes to the brain. So if we can get in there earlier, intervene, and maybe prevent that from happening, that could have a much better outcome from our schizophrenia patients. So how can we do it? Well, again, with imaging, the idea is that you take all those people at risk, scan, get blood measures, cognitive tests, etc., and see what likelihood is there of them developing the disorder. So that instead of perhaps medicating everyone at risk, you just target those people that you think are going to transition. Now, there's an ethical issue about, of course, giving every person at risk some of the nasty antipsychotic agents we have currently available, but hopefully there'll be new generations of drugs coming along in the coming years. But you can see structural changes that occur in that at-risk mental state between those that transition, T, versus those that don't transition. So this is a potential future predictor and a biomarker. Early days, this is work from Germany. People are trying to corroborate this. They're scaling it up now across many centers, Australia, in combination with a whole plethora of European countries involved in doing this, and watch this space over the coming years. I'll take an example from neurology. Our movement disorders clinic at King's has people present with Parkinson-like conditions. So it could be idiopathic Parkinson's disease, or it could be something much more aggressive, a PD plus disorder like multiple system atrophy or PSP. So if only they could tell from that initial evaluation which type they had, again, the type of treatment that you would give would be completely different. You may go for something much more aggressive, like a regenerative medicine strategy if you've got PSP and MSA, versus something like idiopathic Parkinson's disease, where the conventional dopamine agonists seem to do a good job. So again, this is where we've come in. We're using these machine learning approaches. We're looking across multi-class. In other words, we've got 3 different conditions that we're looking at here relative to controls. And we're asking the question, which of the modalities drives that distinction with very high accuracy. Small numbers of subjects in a single center. It's early days, but again, very promising and helpful to neurology. So these machine learning techniques, we've developed a lot of them. They're all available, open source. We've applied them to pain, which I'll mention a bit more in a minute, across all these different disorders, including a social anxiety intervention online where we could predict a response to treatment with a scan as well. Now, this is me. This is a typical scenario. These MRI machines can cost anything from £1 million to £5 to £7 million. And I always have a temptation. I book the scanner and I book my patient in for the scan, and then I'll throw 15 different types of scan at them. I'll throw a spectroscopy scan to look at chemistry, a structural scan, and some functional scans. And the great thing about these machine learning algorithms, they're agnostic. They tell you which one or combination of modalities is really the ones that drive the question you're trying to answer. So we're doing that a lot more these days, and that's really informing what could be the future for diagnosis in psychiatry and neurology. If Reese could start the movie on this, please. Click on the slide, thank you. And of course, the other thing I mentioned at the start about MRI, it's so versatile. If you're not careful, you can make a scan. Could you try that again, Reese, please? Go for it. There you go.
It's coming up.
Oh, it's coming up, sorry, okay. Well, I'll tell you a story whilst we're waiting. So I started working with a chap called Simon Baron-Cohen 20 years ago on imaging and autism. He said, oh, can we scan autistic brains to see what's different from normal? I said, okay, well, give me an idea. Where's the underlying biology? Oh, it's the amygdala. Okay, so we optimized the scan for the amygdala. 2 years later, he said, oh, it's the cerebellum. Okay, we tweaked it for the cerebellum. 3 years later, orbitofrontal cortex could be really important. And now we know it's the whole cortex, the whole brain is involved. So if you're not careful, you can make the wrong type of scan that might be optimized for the wrong thing. Reese, did that run or not? No? Never mind, if it doesn't run, don't worry. So what we've tried to do, and another thing I've worked on over the last few years, is what I call a scan for all seasons. A type of scan that allows you to go back and synthesize an image which is optimal for the structure that you're looking for. So don't worry about it, so I'll skip on. So on this slide, what you'll see is that you can collect all these different flavors of scan that take 5 to 10 minutes each on the top row, or you can actually do this standardized protocol that I've developed. Works on all the different scanner manufacturers at the same field strength, allows us to pool the data from those for these big data approaches with machine learning. And you can synthesize the image that you want in any arbitrary orientation, which is tweaked and optimized for the structure you're interested in looking at. So you're future-proofing the data for further research. And that's, again, making the scanners less different, and it makes it more of a vanilla protocol, but that's definitely the way we need to go, like genetics has done over the last few years, and standardize these things are done across centers. The same technology allows us to not only get the structural information out of the scan, but you can also tease out a component of the water signal in the scan that's the water that's stuck to the myelin. So this is called the myelin water fraction. So we're able to tease this out. We could prove it in our rotating mouse brain at the bottom, which you can take out and section and stain afterwards. Take it back into a positive control condition like multiple sclerosis, where you see on the top left-hand side there, in dark blue, the areas where there's loss of myelin, which might not be apparent on a conventional MRI. Then also showed it worked in the spinal myelin mapping as well as in the brain. Much better correlation to disability scores than conventional FLAIR. And then brought it all full circle back into psychiatry in the bottom right-hand corner, where we're looking at the brain maturing in the first year of life. If you look at the bottom left, you'll see the first bit that matures as the baby is born is in dark blue, is your brainstem and your cerebellum, because you need to be able to breathe for yourself. But over the next 6 to 9 months, you can do that silent MRI with a sleeping baby, and you see the brain mature. You see the corticospinal tracts mature here. And then the very last bit of the brain that matures is the frontal cortex. So we can do that studies, and then now we're starting to look at young boys who have an older brother that's been diagnosed with autism, because there's a 1 in 4 chance that that younger brother will also have it, to see whether we can pick up very early in life a developmental delay and a change in the maturation processes through this type of technology. So watch this space. Oh, right. So I've got a little bit of time left, haven't I? Ian's nodding, good. One technology that we're using that's really impacting, I think, on drug development is something called arterial spin labeling. This is a simple animation that explains how it works. You're lying inside the MRI, we've done our structural scan, and having done the structural scan, the next thing we're going to do is we're going to apply some radio frequency to the neck. So you apply an RF for a second or two. That effectively tags or labels the arterial supply. And about 1.5 seconds later, you image upstream in the brain. So you're making a scan with this tagging on at the bottom, the neck, and a second scan with the tag off, and the subtraction of the two is just those perfused spins. So you can make an image of the cerebral blood flow in the brain without having to apply any contrast agents or any radioactivity to be able to tease out a quantitative cerebral blood flow map. So this is a whole head, 3 millimeter sort of isotropic scan in a few minutes that allows us to look at the perfusion in the brain. So if we have that type of perfusion scan, then you can start looking at the functional modulation of drugs. So a very simple application here would be take our subjects, 1 visit they're on placebo, 1 visit they're on a drug to treat schizophrenia, haloperidol. The difference between the two, you get the central effects. So you can show the central modulation of that drug. Now that's not tracer quantities like you might be accustomed to in PET, but it's giving you some insight about is the drug having a central effect? What's the right dose to give you the optimum functional modulation, and exactly where in the brain it's hitting, which gives you some insight about potential indications for that drug. It's not uncommon for us to have someone walk in with a cognitive enhancer. We do this type of study and they walk out with an analgesic. I kid you not. So we've done those studies, and that has helped to inform future secondary indications for many drugs with pharma collaborations in the past. This is a busy slide, but to cut a long story short, taking information like that perfusion scan, which is in the middle of the picture, aligned with data that we have in our libraries and now about receptor occupancy from PET, and some of the messenger RNA from histology in the bottom, we can now develop calibration curves where you can correlate perfusion versus D2 receptor density and get some idea about where these drugs are hitting and how many D2 receptors you have in your brain. So one day, it sounds a bit far-fetched, but you can imagine a precision psychiatry scenario where a new patient comes in that's recently been diagnosed with schizophrenia. You give them this perfusion scan with a single shot of a drug like haloperidol. We'd be able to infer the D2 receptor distribution and then give some idea about what drug dosing we should use for that subject. Early days, but very exciting, and this is the sort of stuff we're doing at the moment. Back to pharma, we worked with Lilly some years ago on a drug that came to market called Strattera, or atomoxetine as it was called then. And they wanted to make sure that this drug wasn't just like Ritalin, wasn't exactly the same as methylphenidate. There was no point taking a drug to market that's going to be exactly the same because the other is generic, it's cheap, and it's not going to be working in that 30% of patients that are treatment resistant to the frontline medication. So what we did again was that ASL study. You inject it into the brain. You see in red where the Ritalin hits, and you see in blue where the Strattera or the atomoxetine hits. And you can say, okay, it definitely has a central effect. It's not exactly in the same bits of the brain, so there's some potential that this drug might work. So this can inform phase 3 studies as well as some early phase 2 and phase 1 information. So watch this space. Oxytocin, the love hormone. You hug someone, you pat your dog, you release more oxytocin. And we believe in conditions like autism and in schizophrenia, where there's poor social cognition, oxytocin-like agonists might be really useful here. Now, the only way that we currently have to administer this is intranasally. So we've done these studies involving the perfusion imaging whilst the oxytocin is given intranasally, and you can see the central effect of the drug. And you can see from the pharmacodynamic profile when it's having a central effect at maximum. So this can inform future studies, and our psychologists have been very excited about this idea where you could imagine applying cognitive behavioral therapy, talking therapies, whilst this drug is on board. And you know that sweet spot post-oxytocin administration that you're going to be most receptive to this intervention that could improve social cognition. So early days, and of course we're trying to think of druggable targets instead of this, so I can go into that later, but that's showing where we might go. This would be a damn sight easier sitting up in your hair salon scanner than lying down, but it still works. Sue asked me to put a couple of slides in about pain. What are we doing in pain research? Well, across the road from our scanning center, we have a big dental institute, and they pull wisdom teeth, third molar teeth out by the dozen, by the day. So we grab some of these poor people and scan them before they have their wisdom teeth removed, and then they're completely fine and not in pain. And then they have their local anesthetic, the third molar removed. Unless you're Australian, the first guy we ever did was Australian, didn't feel any pain after his bloody extraction. So we thought this has all failed. And we scanned them on a second time when they're in post-surgical pain. So you can look at the brain in pain versus no pain. And again, the comparison between the two, you can tease out the main effect of pain in this group. And of course, you can imagine designing quite neat studies where they come along on one occasion, they're not in pain, they're on placebo. Another occasion, they're not in pain, they're on drug, so you get the main effect of the drug. Then on another occasion, when they're in pain, with and then without the analgesic. So you do bottom left and bottom right and so on. And in those sort of studies, and Pfizer funded these, we were able to then take drugs through and prove efficacy of new analgesics in half the time with about a quarter of the subjects, getting some information about the central effects and half the cost because of the less number of subjects. And we were doing it at a single center. So that could inform early phase drug development in the pain research area as well. And they were asking us, well, yeah, this is great. And I know you have a terrible habit when you put your patients inside the scanner. You can't stop yourself from doing other things. What else could you do if you were given 10 minutes? Could you look at abuse liability? Most of these drugs that we use for treating pain have some potential of abuse liability, the opioids in particular. What would you do? Well, I said, well, what we could do is they're lying in there, and we can get them to play a game where they're anticipating a reward. They see a circle on the screen, they're going to win £1. Used to be worth a lot, not so much these days, but we're expecting to win £1. So we'll be scanning while they're expecting to win that £1 when they press the white button. On a second scan, they might be seeing a circle with 3 lines in the middle. Now they're expecting to win £5. And then, of course, there's a neutral condition, which is the triangle. So we look at the brain scan when they're anticipating the reward. So you get this network that lights up when you're anticipating rewards. This is like the hedonic network. So the ventral striatum or nucleus accumbens, if you're a preclinical specialist, lights up when doing this type of task. So you can start to ask questions, well, if the drug is ameliorating the pain and not hitting this hedonic center, then you're onto a winner because you're not having abuse liability being sort of modulated by this. And that's the mindset, again, with some pharma companies at the moment, of thinking about the safety as well as the efficacy in the design of their imaging studies. But our MRI, and I mentioned in my title, From Mouse to Man, is also safe for our rat and mouse studies as well. So we have a preclinical scanner that's like one of our baby scanners that we can actually allow us to look at brain scans in the mouse and the rat. And there's a lot of exciting new transgenic rat and mouse models coming along for looking at dementia, which I won't go into now. But here's a study that we did a while ago with Lily again, where we looked at the main effect of ketamine. So Special K, as it's known in the Brixton nightclubs in London, is a drug that's widely abused, but has a psychomimetic effect. So you can use it like an experimental medicine model of schizophrenia. And you look at the central effects of that in a rat, where they have hyperlocomotion. You can also do exactly the same experiments in the human. So having got this up and running, then you can do pre-dosing with antipsychotics to see if you can block the central effect of ketamine, and which we've done with lamotrigine. We've tested it in some other drugs as well, to look at the glutamatergic system and seeing whether we can be looking at potential new treatments for schizophrenia that are not classic dopamine agonists. So that shows you where you can do translational research from a rodent on the left to the human on the right. Oh, sorry. And also you can, because of the temporal characteristics of the MRI, you can tease out the temporal dynamics and when that drug's hitting the brain. So this could inform the formulation, it could inform the route of administration. If you're thinking of giving ketamine for depression and giving it intranasally, you might want to know when it hits the brain and how long it lasts for, as opposed to giving it via another route. So that could really inform prescribing habits in the later in the future as well. So this is the sort of insight and information you can get out of these types of scan. Some drugs, like the AMPA potentiators, these allosteric modulators that you'll maybe hear a lot more about today, may be drugs that you struggle to make PET ligands for. So again, this is where the MRI comes in. So this is some work that we did with Mark Tricklebank some years ago, where we looked at AMPA potentiators, or AMPA-kines, and looked at the central effects of those in the rat. And then we blocked them with AMPA antagonists as well. So that shows where this technology can go. And if you can get it to work in the rat, it's a breeze doing it in subjects, because of the size of the brain is less than my thumbnail. And you have challenges of anesthesia and all these other things that you have to deal with as well in the rodents model. In the last few minutes, this is probably the clarion call for me. This is a slide from 2004. It's 12, 13 years old now, but it's still very apposite today. This is a study that Michael Davidson did where they looked at 100,000 conscripts to the Israeli army, males and females, followed them up over many, many years. Many of them developed these psychiatric disorders. And they went back to the original notes and they asked, what the hell was it that made them at risk of developing depression, PTSD, schizophrenia, affective disorders, etc.? What was it? And the continuous theme across all of these disorders was poor cognition from the outset. So if you could develop a drug to enhance cognition, don't think of it just for dementia, don't think of it just for depression. It's going to be something that's going to have an impact across the myriad of mental illnesses. So this is showing you where we need to be going with this. So how are we going to do it? Well, Tim Bussey and colleagues followed on from Trevor Robinson's work on Cantab, and they now have touch screens that allow us to look at cognition of the mouse and the rat. They touch the screen, and then they go back and get the reward at the back when they rememorize something from before. So that's where they went with this work, at the same time as we have been doing the experiments inside the human scanner, where we have Cantab, as it's called, working inside the scanner, where we can look at the same types of tasks where you look at the screen, have to memorize that first abstract picture, it goes away, and remember which one of the four presented on the screen is the one you saw before. With things like depression and dementia, then of course you struggle to do this. And so we've been doing these experiments and got the functional neuroanatomy of those tasks, which then links back to the rodent work, which can have a benefit in informing where we go with these studies. And in a weekend, with 14 subjects doing this task, you can build up the functional neuroatomic atlas of the whole brain for that task to inform the drug development process at a very early stage as well. And you're not just limited to working with Cantab. Keith Wesner's and colleagues had a company called CDR, Cognitive Drug Research, which one of their core battery was digit vigilance, where you look at the screen and you're looking for every time that number 8 appears, press the button. And again, we were able to provide him with the functional neuroanatomy for that task. So we're not saying scan everyone, but once you've done this type of study inside the scanner, they can take that information and use it when they're trying to get some insight about performance online in large samples or in smaller trials in early phase 2 as well. Last 2 slides. We do this task a lot. Let's see if you're all still awake. So you're lying inside the MRI scanner. You look at that first little face on the screen. Now you have to decide whether that face is female or male. That's all you're asked to do when you're inside the machine. So hands up how many people think that face is female. Quite a few. How many people think it's a male? A few. Well, actually, it is actually a female, but we make it difficult by cropping the hair so that you take a closer look. But the challenge, what we're trying to really do is we show a picture, then we show another picture. What we do is we morph the faces to go from very neutral to more and more sad. And what happens is the more depressed you are, the more you empathize with the saddest face, and you actually perceive the neutral face as pretty sad as well. So as some of my academic colleagues, it's like before you submit a grant, when you're waiting for the reviews, and when you haven't got the grant. So that's a typical scenario. So from that type of scan, we can see the differences in the brain in the depressed cohort. Machine learning again, you can cause this distinction with 85% accuracy. Punch the air and you go and see people like Alan and say, I've got a new way to diagnose depression with this bloody expensive scan. And they say, well, why don't you just ask them? So there are times when you do a scan that are not necessary, but the exciting element of this work was that all those little circles, which were the patients, were then put onto Prozac, onto fluoxetine. And from that baseline scan, we could predict with over 80% accuracy who was going to respond to Prozac, which you wouldn't know for a couple of months from the clinical symptoms. So that could inform, again, precision psychiatry in the future. That's an exciting avenue for us to go down from now on. Is it a one-trick pony? We repeated the experiments with talking therapies, in depression again, and again, over 80% accuracy, even though 50% of people responded. And from that type of scan, we could tell the more pristine, the better your hippocampus was to start with, the more likely you were to respond to talking therapy. So you can learn a lot from this process. So just to finish up, I've hopefully enlightened you a little bit about what we're trying to do with MRI in the psychiatry. I'm trying to see where we can go in terms of impacting on drug research and development. I started off life many years ago working at Beecham. That shows how old I am. Before they became SmithKline Beecham, before they became GSK. And so we never had this type of technology available. So I think the imaging is just the only really way we can get at the brain biology in psychiatry. Can allow us to look at the central effects of drugs, give you some idea about what dose might be right in terms of the functional effects. You can see from the bits of the brain that are modulated which indications it might be relevant for. So if it hits the insula and the thalamus and the anterior cingulate, you go, oh, this could be really good for pain. And we've done those studies before. It can also help you decide which bits of imaging are important for future trials if you are going to go into phase 3. You can do within subject designs, as I showed you again for pain, so that can reduce the number of subjects. And even though it's high tech, it can actually reduce the costs. You get the PD profile as well, so that could inform, as I say, formulation of subsequent prescription habits. And you then can do things like ask the question, is this drug just like the rest of the drugs that are on the market, or is there something distinct about it that could be relevant to a new population that are treatment resistant? So thank you for listening, and thank you to all the people for sponsoring, and I'm sure we can take questions later or something, but thank you very much.
So we do have a few minutes for questions, if anybody has any questions for Professor Williams.
I want to hear questions from this lot in particular. And there's no such thing as daft questions, trust me. I've worked with psychiatrists a long time, so.
we have one over here.
Oh, sorry, hi.
Fantastic talk. So
Thank you.
My question is, in the area of psychiatry and pain, there's a very strong placebo response.
Mm-hmm.
And I'm just curious, when you image patients that are on placebo, do you see the same sorts of changes in cerebral blood flow that resemble a pharmacological response?
That's a really good question. Yeah, a lot of the studies aren't designed in the best way to look at that. And a really good way to design a study would be, let's say, whether it's pain or depression or anything, is have potentially everyone on placebo for the first 2 weeks. We scan them at baseline, we scan them at maybe 2 weeks, and then you bifurcate your study onto drug or not. There's some preliminary work from PET which showing differences in the underlying dopamine receptor distribution, but hardly anything done with the fMRI. With conditions like fibromyalgia, where you've got the combination of pain and depression, that's an obvious way to go. We do a lot of work on hypnosis and suggestibility, and again, that's partly in the context of using it to treat addiction and treat chronic pain. And out of those studies, I think we'll get a much better insight about placebo, but it's a desperately under-researched area. And boy, do the pain researchers need it because of the placebo response. Hi.
Wondering if you can comment on where MRI technology will stop and something like MEG will take over.
Ah, good question. So MEG is this type of technology which really, instead of looking at the downstream effects of activity in the brain, which is what you do with the MRI, because you're looking at changes in blood flow and perfusion and oxygenation, the MEG allows you to look at the real sort of activity, neuronal activity in the brain. Every MEG company has gone bust over the years because I just don't think they seem to be able to scale up. And to use an analogy, a lot of the technology scratches the surface. You're only really getting information from the cortical surface. And of course, most psychiatric disorders, you're desperately interested in the deep grey matter and the hippocampus and so on. Having said that, there is a new type of MEG coming along, which is called optically pumped MEG, which is going to be a device which you can wear like a helmet and potentially walk around with, akin to EEG, and watch this space. But again, for time, I didn't put it in today, but a lot of our studies, we do integrated EEG and MRI to get at both the activity and the hemodynamics. But yeah, EEG, MEG, cheaper we can make it, the better. Hi.
Wonderful talk, thank you. I wonder if you could speak a little bit about how you interact with the regulators in thinking about how these endpoints are compared with the accepted gold standard and moving towards the newer.
Yeah, so we went into the EMA, which is the European equivalent of the FDA, with Roche recently to look at sort of development of biomarkers for autism research. And they were very receptive. They're desperate. And you may hear this during the course of today, how there seems to be a sea change at the moment where the FDA and everyone is dealing with new treatments for psychiatric disorders, whether it's BNC 210 for PTSD or what we're trying to do with Roche in autism. So they're really desperate for us to come in with this ideas and insight. And if we can get drugs onto market in a few years quicker, then there's an open door, which is very exciting. So yeah, engage with them early. And I was rather worried about this initially, but they've been very supportive.
Have you done any work to try and sort of look at genotype of your patients in the scanner so you can start to sort of correlate phenotypic effects of imaging with genotype and sort of start
Yeah.
to see sort of patient population?
That's interesting. So if people couldn't hear from the side, have you sort of tried to link genes with imaging in your research? The next 2 days, I'm going to be banging away on my computer on a grant on twins. We have an amazing database at the Institute of Psychiatry of 20,000 twins from early development. They're now at 21. They've never been scanned. These 20,000 kids have been mapped from birth over the 20 years. We know everything about their environment. So you can imagine out of that 20,000, we still have access to 4,000 twin pairs who are identical genetically, and but have gone down different paths in lives, and you have them being discordant for disorders like anxiety and depression and so on. So obviously there's something in their lives that's happened in the environment that's caused them to go down these different paths. So we've never had a look at their brains to see where the influence of environment versus genetics has come in. But that's something we're desperate to do, given grant funding in the next few years.
One more question, I think.
Do you think these techniques will change diagnostic categorisation?
Yeah, I tell you, I've been at the Institute of Psychiatry for over 20 years now, and there would be 5 or 6 world leaders in schizophrenia would come in with their cohort of schizophrenia patients. And they'd say, show me the schizophrenic brain, and show me what's different in the schizophrenic brain. And I'd say, just meet me halfway. Just let them come in with the same symptom. You know, you'd have one with negative symptoms, one with positive symptoms, one with hallucinations, one without hallucinations. So I think this is coming back to Anne's question earlier. I think we have to treat these psychiatric disorders as a continuum of the normal population. So if we can scan those 10,000 twins and look at, let's say, anxiety from all the way along the continuum, that 5% at the one extreme will be those ones which we classically diagnosed with the disorder. But if we have all that information, we can say, how is the brain change in function, metabolism, structure over scaling with the dimensions of symptomatology? Instead of thinking of depression or anxiety, it'll be this symptom, and we're going to have a drug for that symptom, irrespective of the disorder. So I think it'll be very informative. Well, whatever we've had in the last 40 years hasn't worked, as it were, the drug for schizophrenia or the drug for depression. So we've got to have a completely new approach. I was going to say paradigm shift, but I thought that was too cheesy. So that's it. Thank you.
Thank you so much.
Thank you very much.
Okay, so our next speaker is Anne Hayes. Anne is an independent pharmaceutical consultant based in the UK. She completed her PhD in pharmacology at the School of Pharmacy in London, and then worked for over 20 years at Glaxo, and had a number of positions of increasing responsibility, including being therapeutic director for CNS disease. In 2001, Anne left Glaxo Wellcome and set up as an independent consultant, as I mentioned, and since then she's co-founded 3 drug discovery companies and sat on the boards of several others, and she continues to consult for a number of companies and venture capital groups, principally in the area of CNS drug discovery. And as you can see from the slide, she's going to talk to us today about multiple mechanisms for pain. How can we improve the chances of success? A very important topic for the industry. So, Anne.
Well, thank you very much for inviting me to be here today. It's always wonderful to come to Adelaide at this time of year. I'm on the SAB of Bionomics, and I've been coming for about 10 years. And it is lovely to come from damp and dreary London at this time of year and come to sunny Adelaide, although my daughter texted me yesterday to say that it's about the same weather in London at the moment as it is in Adelaide. Anyway, it's still good to come and meet the Bionomics people every year. So I'm going to be talking about drug discovery for novel analgesics. So just to give you a little bit of background about pain, there are a number of different types of pain. You'll all be familiar with this type down the bottom left, nociceptive pain. That's where you stick your hand in a flame, you feel pain, you say ouch, and you take it out pretty quickly. And that sort of pain is caused by potentially tissue-damaging stimuli. It has a defensive role, and it's a fairly simple physiological pathway. So you have a simple pathway along peripheral pain afferents into the spinal cord and up to the brain. That type of pain is relatively unimportant for chronic pathological pain of the sort that we treat in patients. And of much greater importance are these other types of pain. Functional visceral pain, I'm not going to say a lot more about that today. This includes things like fibromyalgia and irritable bowel syndrome, sometimes caused by visceral stimulation. Often we don't know what the cause is. They're quite difficult to treat, these sorts of pains. Could be the subject of a whole lecture in its own right. I'm going to concentrate on today on the two at the top, neuropathic and inflammatory. Neuropathic pain is basically caused by damage to neurons. It includes things like diabetic neuropathy, postherpetic neuralgia. And it's caused by fairly complex pathways in the periphery and the brain. There's not a simple pathway from the periphery into the brain, and particularly important are sensitization mechanisms, both in peripheral nerves, but also within the spinal cord and in the brain. Inflammatory pain is important in things like arthritis. It's caused by tissue-damaging stimuli, and you get release of inflammatory mediators. it also involves these sensitization mechanisms, which are really important in its pathophysiology. What drugs are used to treat these types of pain in the clinic? Well, you'll all be very familiar with paracetamol and non-steroidal anti-inflammatory drugs like aspirin and ibuprofen. They're pretty effective if you've got a relatively mild sort of pain, but as disease gets more advanced or as the pain gets more severe, they become less effective, and you've got to resort to other things like potentially opioids, although people are, certainly in the UK, loath to use opioids on their own, so combinations are used much more extensively. So in the UK, a combination of something like codeine and paracetamol would be very common. For neuropathic pain, the gabapentinoids are the mainstay of treatment, so things like gabapentin. Traditionally, amitriptyline was used quite a lot. This is a monoamine reuptake inhibitor antidepressant, and other antidepressant drugs are also used. Opioids are used relatively little in neuropathic pain because it's simply less sensitive. But local anesthetics like the lidocaine patch are used where there is a local site that can be accessed. So what are the problems with all of these drugs? There's quite a few of them, but they're all old drugs. Paul Rowland was telling us at the dinner last night, he's a pain clinician. We have a 3,000-year-old drug that we use, that's opium, and we have a 100-year-old drug that we use, which is acetylsalicylic acid. So they are pretty old, some of these drugs. They all have efficacy problems. We've talked about opioids and NSAIDs. If we lump together all the drugs that are used in neuropathic pain, and there are quite a few of them now, they really only treat successfully about a third to a half of the patients, and the others don't get any successful treatment. And they all have a range of pretty nasty side effects, so they're far from ideal. So that probably explains why there's been a huge effort. You know, I've been in the pharmaceutical industry nearly 40 years now. I started off working in pain, and we've been going on ever since. There has just been a huge effort to try and find new and better drugs. There have, sorry. Sorry about that. There have been some successes over that time, but unfortunately, a much longer list of failures. And these are failures in the clinic, failures for lack of efficacy. So at a time when you've already spent a lot of money on these drugs, and they're failing in the clinic. So what can we learn from these successes and failures to try and improve our chances of success? I actually got together with two colleagues a couple of years ago, and we kind of reviewed drug development in the pain area, and we wrote a review on it to see if we could pick out some themes that potentially would stave off this long list of failures. So the first conclusion that we came to is that if you could, it would be ideal to use some sort of clinically validated mechanism. You know, the failures of failing in the clinic, having worked in animal models. So if you could use a mechanism that is at least partially clinically validated. So if you think of COX-2 inhibitors, that's drugs like Celebrex, they are partially clinically validated by the use of NSAIDs, which are non-selective COX inhibitors. So the idea here was to produce a drug selective for COX-2 and produce analgesia, but get around the GI side effects by eliminating COX-1. As I'm sure you're aware, they had other problems that I shan't go into. Gabapentinoids work on calcium channels. That then became a precedented, a clinically validated mechanism and led to the development of something like ziconotide. We talked about amitriptyline as an antidepressant drug, a reuptake blocker, so this has led to the development of other more selective uptake blockers. So the sort of theme here is to take a mechanism that is at least partially clinically validated and to build better selectivity into the compounds. Again, if we look down this list of the failures, many of these are completely novel mechanisms. And you know, I'm not standing here and saying, well, you should never work on a novel mechanism. I'm a scientist. That would be a fairly silly thing to do. We really do have to bring novel science forward. But I guess what I am saying is one has to appreciate that the risk you carry with that entirely novel mechanism is much higher, and you need to think of other ways of perhaps mitigating some of that risk. So, talking in a little bit more detail about some of these clinically validated mechanisms with inhibition of voltage-gated calcium channels. Gabapentin was originally launched for epilepsy, and it was tried in neuropathic pain because anticonvulsants were used at that time in neuropathic pain, so things like carbamazepine and phenytoin. It was only after it was shown to be effective in neuropathic pain that the mechanism was elucidated as inhibition of this alpha-2 delta calcium channel subunit. It led to the development of pregabalin by Pfizer, which is essentially a lookalike drug with a somewhat better PK profile, but perhaps more interestingly, it led to the development of this drug, ziconotide. So ziconotide is a selective N-type calcium channel inhibitor. The gabapentinoids interact with this alpha-2 delta subunit here, and in doing so, they inhibit a range of voltage-sensitive calcium channels. People were particularly interested in the N-type calcium channel because it's located on presynaptic terminals. It inhibits release of transmitters which are important in pain, like neuropeptides and glutamate. So this compound ziconotide was developed as a selective N-type calcium channel inhibitor. It was tried in patients with very severe intractable pain. As you can see the data down here. So these were patients that were not responding to any other type of drug. And you can see the drug is producing a significant effect even in this highly intractable population. The downside is that it has to be given intrathecally. It's got to be given directly into the spinal cord, which is pretty invasive. But you can't give it systemically because it has major effects via N-type calcium channels in the heart. So the next stage in the story was to try and develop compounds using this now clinically validated mechanism, but with a better therapeutic index. And the mechanism here was to use this use dependence. What this means fairly simply is that the compound only interacts with the channel when it's being used, when it's either firing at high frequency or it's depolarized. So in other words, if the neuron is transmitting pain impulses, then the compound will inhibit it. If the neuron is quiescent, as potentially the neurons in the heart may be, it shouldn't. And this compound from Convergence was developed as a use-dependent, a state-dependent inhibitor. It was well tolerated in phase 1, didn't produce any cardiovascular effects. Unfortunately, it was inactive in 2 phase 2 studies, as was another compound from Zalicus, both of them state-dependent blockers. So what's going on here? Why did this apparently clinically validated mechanism fail? Well, it could be the wrong target. It seems unlikely given the activity of ziconotide. It could be that the compounds in interacting with the channel in a somewhat different way aren't as effective. It could be the wrong clinical population, although the drugs were tried in a number of different types of pain, so that seems a little bit unlikely. I don't know the answer to this, but I suspect one key issue here was whether the drugs were actually demonstrated to be producing target engagement at the dose that went into the clinic in the brain in man. And that is quite difficult to do if you're looking in man, in the brain. Hence, it was really interesting to hear what Steve had to say this morning, because clearly there are ways that we can do it now, but we really need to be starting to think about doing that early on in the drug development process. So moving on to another clinically validated mechanism, inhibition of voltage-gated sodium channels. This is validated by the use of local anesthetics and anticonvulsants, which are both state-dependent sodium channel blockers. These compounds are effective in neuropathic pain, but they have a poor side effect profile if they're given systemically. Local anesthetics have major effects on the heart if they're given systemically, for example. I think here the issue was probably that they are non-selective blockers. So the question then was to go on and build in selectivity. And there are, as you can see, a number of different types of sodium channels. Which of these channels should we choose? And the three at the bottom here, 1.7, 1.8 and 1.9, they're really interesting because they're selectively located on pain-sensing afferents. So that should be a really good way of getting an analgesic which has a better side effect profile. Potentially there are central channels like 1.3 that are also involved in pain. What you really want to avoid is these channels, particularly this NaV 1.5, which is the channel in the heart. But which of these other channels should you choose? And that brings me on to another major theme of my talk, which is choosing mechanisms which are validated by human genetics. And there's a lot of work going on at the moment showing that there are genetic mutations which are associated with particular types of pain syndromes, and that is producing a really good target validation in man. And that leads on to this channel, the NaV 1.7 channel, where there are gene mutations which have shown really interesting associations with pain. So there are gain-of-function mutations which produce this syndrome called erythromelalgia, where patients get intense pain in their hands and legs. And there are also loss-of-function mutations which lead to insensitivity to pain. So this is right from birth, and these patients are always injuring themselves because they don't have the defensive mechanism of pain. So this became immediately a really interesting target, and many companies across the whole pharma industry became interested in this channel for pain. And I've picked out here 3 compounds that have been into the clinic and for which we now have efficacy studies. The compound at the top, vixotrogene from Convergence, it has good selectivity against the cardiac channel, which you really do want to see. Actually less good selectivity against some of the other NaVs, but that might be interesting because if they're the NaVs that are involved in pain, like 1.8 and 1.9, that could be useful. It's state dependent, so that's good for producing a good therapeutic index. And it produced good efficacy in 2 trials for neuropathic pain. Funapide from Teva, that is selective for 1.7 and 1.8. It was effective in erythromelalgia patients. Unfortunately, in PHN, it missed its primary endpoint, although it did have an effect against some of the secondary endpoints. But it was given topically for reasons that I don't know, so it is quite possible that it simply didn't reach the site of action in sufficient concentrations. And then we come to the compound at the bottom from Pfizer. This is highly NaV 1.7 selective, also state dependent, doesn't get into the brain. It had no effect in the clinical trials where it was tested. So what is going on here? You have a highly selective compound that was inactive, and I don't know, they may know inside Pfizer why it was inactive. I don't know whether it had PK problems. Perhaps somebody else in the audience will know the answer to that. I guess what we do know from this is that a somewhat less selective compound where the therapeutic index is conferred by another mechanism, by use dependence, may be a good way to go. And I think that's probably the way. There's still a lot of effort going on in sodium channel blockers. People are moving more towards more non-selective compounds, building in activity. Building in activity against other channels, particularly these other sensory neuron-specific channels. And interestingly, there's now recent data linking mutations in some of these channels to pain states. So maybe there is method in the madness. Moving on to now another very interesting target that's validated by clinical genetics, and that's the interaction between nerve growth factor and its receptor tyrosine kinase, TrkA. There are many different mutations in both NGF and TrkA which lead to congenital loss of pain sensation. And again, this has provided validation that set the whole industry working on this particular target. And there are antibodies, NGF antibodies. There are now some small molecule TrkA inhibitors coming through. But the antibodies are furthest ahead, and these 3 compounds here
have been into a whole range of different pain studies and shown good efficacy in this whole range of different pain types. So a really interesting target, again validated by clinical genetics. They hit a bit of a problem in 2010 because in the osteoarthritis trials, it was noticed that some of the patients were showing increased osteonecrosis and needing hip replacements. So that led the FDA to put them on clinical hold, and there's been a lot of work done since then to try and understand what's producing this issue. I mean, the long and the short of it, I think we still don't understand what the issue is. There doesn't seem to be any direct relationship between NGF inhibition and bone development. If people take the drugs for longer, it's worse. If they take NSAID at the same time, it's worse. But the actual, what's going on here, we don't know. I mean, it may just simply be that people aren't feeling pain, so they're going out and climbing mountains or having dancing lessons. In any event, the FDA lifted their hold in 2012 because they felt that the benefits outweighed the risks. So these compounds are now progressing through phase 3. And I think it would be really interesting to see what happens when they get to market. And in fact, tanezumab, the Pfizer compound, has now been given fast track designation by the FDA. And I thought I would just show you some of the data here on tanezumab. This is in osteoarthritis, showing decrease in pain. And we've talked quite a bit about the placebo effect. Here it is. This is a very classic placebo effect that you see in most CNS trials and certainly in most pain trials. But this is the effect of tanezumab. 3 doses, all producing a really good effect, really sustained effect, and this is dosing once a month. So this mechanism, if you get a mechanism that works really well, it will work really well despite the placebo effect, which is likely to be there. And I mean, interestingly, we can have a philosophical discussion about placebo effects, but it may actually be that people who respond to placebo actually respond to the drugs better. So all the efforts to try and get rid of it may be counterproductive. So we've talked a bit about how you might use human genetics, how you might use clinical validation, use the successes to improve the probability of success. What can we learn from this list of failures? Well, I think there are some things that we can learn. So we've talked a little bit about the importance of demonstrating target engagement. And if you're going to take a novel mechanism forward, you really do want to know whether it's your molecule or your mechanism that has failed. So you want to show that your molecule is doing what it should do pharmacodynamically in the brain, if it needs to get to the brain, at the dose you're going to take into the clinic. And this is just not always done. Some of these studies, they did show target engagement, with the NK1 antagonists, did some really nice PET studies, showed really good dose receptor occupancy. The dose that they took into the clinic was producing 80% receptor occupancy. It went into about 9 clinical trials. It was negative in all of them. So I think you can be pretty sure that NK1 antagonism was not a mechanism to go for. But for many of these, target engagement was never shown. And we've heard this morning, it's not very easy, particularly with inhibitors, always to show target engagement in the brain. But there are technologies for doing it now. And I'm really pleased to see that at Bionomics, with their lead CNS compound, they have looked at target engagement in the brain. That's great. So what other thing might we learn from this list of failures? Well, if you look down this list, they're generally targeting a single mechanism. And all of these mechanisms, by the way, worked really well in a whole range of animal models. And maybe if you just pick off a single mechanism, that is enough in an animal. But pain is a really complex phenomenon in man. And maybe just picking off a single mechanism isn't good enough. Or if you're going to, what you might need to do is target a key control pathway. So if you think of sodium channel blockers, potentially they're stopping action potentials along peripheral pain nerves. So you're cutting it off in its prime. That's a really significant control mechanism. If you think about opioids, they work in a number of places in the brain. they're tackling a final common pathway. I mean, they produce all sorts of side effects, but they do work really well. So I think if you're going to just go for a single mechanism, you really need to be clear that it is targeting a key control pathway or a final common pathway. I'm actually not going to talk very much about animal models because I'm coming towards the end of my time. I mean, it goes without saying, all of those mechanisms worked well in animal models. It just didn't translate into man. There is an issue with the animal models. And when I'm consulting for companies, I always recommend a variety of things. I don't think you can't do without the animal models, but I think there are things you can do to help. I'm not going to go through this. If anybody's interested, we can discuss over coffee. I mean, similarly with the pain clinical trials, there are issues there. I'm not going to talk about this in detail because Paul Rowland, I hope, is going to talk about it this afternoon. I see he's gone. He was obviously so interested in my talk that he's gone. In any event, there are all the usual issues with clinical trials that you see with CNS trials: subjective endpoints, mixed patient populations, placebo response rates. But I just wanted to point out these two things. We've talked already about NGF inhibitors. I also just wanted to share with you about a really interesting target in migraine, calcitonin gene-related peptide antagonists. So there are a range of compounds that are going through development. That includes antibodies, it includes small molecules. They're being tested in acute migraine, in prophylaxis by a whole range of different groups with a whole range of different compounds. They all work. So if you have a really good mechanism, they work. So one thing is there are just mechanisms that are really good. The trick is to try and pick those out. So I've come to a set of conclusions here. I'm not going to go through this. We've talked about it as we go through. So I'm happy to answer questions.
So we do have a few minutes for questions.
Sorry, and I was wondering about the NAV1.7 mutations. If you have a gain of function mutation, you have the hands and feet. If you have the loss of function, you have slightly different and more profound pain loss throughout the whole body. Can you explain that or wonder why?
I can speculate. I mean, ion channels, as you know, are very complex things, and these different mutations are in different parts of the molecule, the ion channel molecule. They do different things to channel activation, channel inactivation, and that leads to different levels of functional deficit or functional effects. I think as we start to understand the molecular biology around it and to know how the particular area of the channel that is mutated, how that is translating into channel kinetics, and how that then further relates on to function, I think that will be really interesting from the point of view of the genetics, but it will also be really important from the point of view of the small molecules. Because, as you know, the compounds that work interact with a particular the local area of the channel, the local anesthetic site. It may be that there are actually molecular interactions within the channel that are much better suited to producing pain relief, for example.
Yes, I've always wondered about that.
I have a question about the animal model. So you said that you pointed out the lack of translatability, to put it charitably, but you said you still advise that you should still use them to a company when you consult. In what way would you advise using them?
Well, I think you need to show in vivo activity. You need to show, you can't just take, there was a time when I was working at Glaxo when some of the senior managers said, oh, we should just get rid of all of these animal models, we'll do our cellular screen, and we'll take it straight into man. Well, you clearly can't do that for a whole range of reasons. You've got to show that the drug gets on board, that it does something interesting when it gets on board, start to do some scale-up on dose, for example, some PK/PD modeling, and just to give you some idea of whether you're affecting inflammatory pain or neuropathic pain. So you can, you've got to choose. There's a whole range of pain syndromes that you can choose to go into. You've got to decide which is the best one to start off with. So I don't think you can completely bypass them, but I think you just have to have a healthy skepticism, try and get it into man as soon as possible. So I wouldn't. I know a lot of companies do a whole range of models, from mice to rats to primates, etc. I always say to people, do a couple of models, interesting models in rats or mice, and then start to develop it to take it into man as soon as possible.
And I guess having a target engagement biomarker is
Absolutely,
is a key part of that.
absolutely. And I think for pain, the fMRI and things like that are just going to be really important. Well, as Irene Tracy has been telling us for many years.
Any other questions between us and the tea break? Yes? Go ahead.
Just a general question about inhibiting KORA, so kappa opioid receptor agonists.
I missed that.
Just a general statement about kappa opioid receptor agonists. I guess with abuse, thinking about abuse deterrent opioids in general. Do you have much of an opinion about whether you think they will overcome troubles with addiction related to opioid inhibition?
So it's interesting. I worked on kappa agonists when I was at Glaxo, I think about 30 years ago. They have a range of problems of their own. They are less abuse, they have less abuse potential because they're dysphoric, so people don't like taking them. Interestingly, I've somewhat peripherally been following the story of a compound called Olimba. I don't know whether other people have heard that. It's a new agonist, but it is what is called a biased agonist. So it actually selects for a particular signaling pathway, the G protein signaling pathway against the beta-arrestin signaling pathway. And their idea was that if that would be beta-arrestin was producing the side effects, and the G protein signaling pathway was producing the analgesic effects. And they've actually just had some phase 3 data which didn't look very exciting, and their share prices tanked. But in fact, the thing they didn't separate out from was the addiction liability, because that does appear to go to the G protein coupled pathway. And you from Australia, but if you live in the US these days, prescription opioid dependence is reaching epidemic proportions, and that is the thing that people are really worried about with opioids.
Okay. Before we thank Anne again, I believe the tea break is upstairs. Yep, Sue's nodding. So go back to where you got your badge, and just opposite of that, there should be some tea and coffee if we're lucky. Please be back here by like 10:55, so we can get started on time for the next session. And let's thank both speakers again. So,